The main presenting problem for this patient is chest pain. As outlined in the case study, the patient Matthew, a 32-year-old male, is experiencing shortness of breath and intermittent chest pain. The central chest pain is described to be 8 out of 10, sharp and stabbing in nature, and worsening when leaning back and coughing. The provisional diagnosis for this patient is acute pericarditis. This refers to the sudden onset of inflammation of the pericardium in response to injury. It can be with or without pericardial effusion, which is a common complication of pericarditis, where fluid accumulates in the pericardial cavity. The patient reported feeling unwell for the past 4 days, with cold and flu-like symptoms, which were suggested by a GP to be viral. Amongst a variety of causes, viral infection is the most common cause of pericarditis. The presence of this risk factor adds to the suspicion of this diagnosis. Diagnostic features of pericarditis include chest pain, which is commonly described as sharp and pleuritic, whereby the chest pain is worsened with deep inhalations. The patient felt the pain was made worse when leaning backwards. The lean and lay test is a hallmark feature of pericarditis diagnosis. Auscultation can be used to assess for pericardial friction rub, whereby the rubbing together of the inflamed pericardial layers can be heard on auscultation. This is a characteristic of pericarditis, yet can be evanescent. Pericardial effusion can be determined by a chest X-ray. Also, ECG changes of pericarditis include widespread concave ST elevation and PR depression. These features support the provisional diagnosis of acute pericarditis, especially since these symptoms have had a sudden onset for this patient.
Let's walk through the 12-lead ECG interpretation step by step. To start the ECG analysis, we must complete a safe check. Whilst I can confirm both the amplitude and electrode placement, there is no way for the speed and frequency to be determined. More information would be required to make a more definitive conclusion. We can start by assessing the rhythm and rate. We can calculate the heart rate using the 300 method or the 1500 method, which is more accurate. This is done by counting the number of small squares between two consecutive R waves. We can then divide 1500 by that number. In this case, that is 21, which gives us a result of 72 beats per minute. If we now take a look at the rhythm, we can see the spacing between the QRS complexes are consistent, showing that the rhythm is regular. Next, we can look at the P waves, which as seen in AVL are present upright, and there is a one-to-one relationship between the P waves and the QRS complexes. This is consistent with normal atrial depolarization. Now we can interpret the PR interval, as shown in V1. Each small square on the ECG paper represents 0.04 seconds. In this ECG, the PR interval spans 5 small squares, giving us a result of 0.2 seconds, falling in between the normal range of 0.12 seconds to 0.2 seconds. If we look at the QRS complex in V2, we can see the QRS complex spans 2 small squares, giving us 0.08 seconds. This is within the normal range of 0.12 seconds, indicating normal ventricular depolarization. We can now move on to assess the ST segments and PR segments. Widespread ST elevation and PR depression are key findings. In leads 1, 2, AVL, AVF, and V2 to V6, we can observe concave ST elevation with corresponding PR depression. This is a common pattern associated with acute pericarditis. In lead AVR, we can also see reciprocal changes with ST depression and PR elevation, which is typically seen in acute pericarditis. In summary, the ECG shows widespread concave ST elevation and PR depression, consistent with acute pericarditis. Additionally, characteristic of this condition are the reciprocal changes in lead AVR. These findings point to a possible inflammation of the pericardium, which should be promptly evaluated and clinically managed.
Acute pericarditis refers to the sudden onset of inflammation of the pericardium in response to injury, whereby fluid is often accumulated in the pericardial cavity. The pericardium is the double-layered sac surrounding the heart. It has 2 layers, the visceral pericardium and the parietal pericardium. The 2 layers enclose the pericardial space, which typically contains 50 ml of plasma ultrafiltrate. Pericarditis can result from infectious and non-infectious etiologies. Some of the various causes include viral, bacterial, fungal, post-acute myocardial infarction, post-cardiac surgery, from trauma, and from systemic autoimmune disease. Inflammation of the pericardium leads to an increase in vascular permeability, leading to an exudation of fluid, protein, and inflammatory cells into the pericardial cavity. This contributes to pericardial effusion, a complication of pericarditis, although pericarditis and pericardial effusion are not mutually exclusive. Major complications of pericarditis include cardiac tamponade and constrictive pericarditis, which both result in the reduction of cardiac output. Cardiac tamponade refers to the pericardial effusion impairing cardiac filling, whereas constrictive pericarditis is the result of fibrotic thickening of the pericardium, impairing ventricular filling, decreasing stroke volume and cardiac output. Pericarditis ECG changes typically follow a four-stage progression. Stage 1 involves diffuse ST elevation and PR depression, whereby widespread changes are seen and are indicative of multiple leads/areas of the heart being affected, rather than a localized region of the heart. These changes arise as inflammation alters the normal functioning of the heart. The epicardium repolarizes faster than the endocardium, presenting as concave ST elevation. PR depression is representative of the delay to the depolarization of the atria as a consequence of inflammation.
Given the patient's clinical presentation, the differential diagnosis of pneumonia and pulmonary embolism must be carefully evaluated. The patient's fever, whilst a clinical feature of pericarditis, also commonly presents in cases of pneumonia as a part of the body's inflammatory response. The patient presents with typical signs of pneumonia, including an increased respiratory rate and work of breathing, pleuritic chest pain that can be associated with pleurisy, and whilst less common, a non-productive cough. However, there are many reasons to be wary when attributing the patient's symptoms to pneumonia. The absence of adventitious breath sounds make pneumonia a less likely diagnosis, as upon auscultation it is more common to hear wheezing, crackles, or diminished breath sounds. Additionally, the ECG changes shown are more indicative of pericarditis than pneumonia. Furthermore, whilst pneumonia can present with a non-productive cough, it is more common to have a productive cough with sputum, which is notably absent in this case. A pulmonary embolism is another important differential that could be considered given the patient's current presentation. Increased dyspnea, tachypnea, and decreased oxygen saturation are all symptoms associated with a pulmonary embolism. Additionally, the sharp pleuritic chest pain that worsens upon breathing or coughing aligns with a PE. The patient's tachycardia could also be attributed to the body's compensatory mechanisms to maintain cardiac output in response to the hypoxia or possible right ventricular failure associated with a pulmonary embolism. Moreover, the patient is presenting with clammy and pale skin, another common indication of poor perfusion and possible shock, which can result from a pulmonary embolism due to compromised cardiac output. Nevertheless, certain indicators make a pulmonary embolism a less likely diagnosis in this case. The ECG does not show signs typically associated with a pulmonary embolism, such as right ventricular strain, the S1Q3T3 pattern, right axis deviation, or an incomplete right bundle branch block, all of which can be linked to this condition. Additionally, the patient lacks major risk factors. Their young age, lack of smoking history, long-distance travel, recent surgery, or known hypercoagulable state further rule out the likelihood of a pulmonary embolism. Furthermore, their febrile state and recent flu-like symptoms are more indicative of pericarditis. Whilst the patient's oxygen saturation is slightly reduced, it is not at a level that would be associated with a pulmonary embolism. Whilst pneumonia and a pulmonary embolism are both possible diagnoses, both can be conclusively ruled out in favor of a more definitive diagnosis of pericarditis.
So, a management plan of pericarditis consists of correctly identifying the key signs and symptoms of the condition to determine the severity and guide the management of the patient. The first intervention that should be conducted is positioning the patient into a comfortable position. Within pericarditis, leaning forwards is common in providing a small relief from the patient's pain. This is due to the physiological process of leaning forward, which decreases the pressure upon the parietal pericardium and reduces the friction between the two inflamed layers during the cardiac cycle. This positional change can help alleviate the sharp stabbing pain associated with pericarditis. In addition to pain relief, this positioning can also serve as a useful indicator. With the patient's pain lowering with this posture, which was mentioned by the patient, it provides further evidence of pericardial inflammation, helping to confirm the diagnosis and guide the following treatment options. In terms of pharmacological treatments, the primary goal is to reduce the patient's pain and inflammation, but also to prevent the reoccurrence of pericarditis. The initial medications used for treatment are non-steroidal anti-inflammatory drugs, NSAIDs, such as aspirin and ibuprofen, alongside colchicine. The use of NSAIDs is due to its inflammatory properties, with studies showing it to be effective in approximately 70 to 80% of pericarditis cases. The choice of which NSAID to use is dependent on the medical history of the patient, alongside potential contraindications which would prevent certain medications from being administered. NSAIDs are preferred in the treatment of pericarditis because they directly target the inflammatory processes that underlie the condition.
Inflammation of the pericardium is a key aspect of pericarditis, and by inhibiting the cyclooxygenase enzymes, NSAIDs reduce the synthesis of prostaglandins, which are mediators of inflammation. This action not only relieves the acute pain associated with the condition, but also helps to decrease the swelling and irritation of the pericardium, encouraging faster recovery. Furthermore, NSAIDs are generally well tolerated and have a rapid onset of action, making them a practical first-line treatment. Among the NSAIDs, aspirin and ibuprofen are commonly chosen due to their favorable safety profiles and effectiveness in reducing symptoms.
Adding to this, there is also the possibility for the NSAIDs to be ineffective or for the patient to have a previously unrecognized allergy to NSAIDs. In that case, glucocorticoids should be considered as a second-line treatment option. While glucocorticoids are a great and effective second option in providing fast symptom relief, they do have some unfavorable side effects. However, in this particular patient, the likelihood of requiring glucocorticoids may be low if NSAIDs are well tolerated and effective. But it is crucial to remain observant for signs of NSAID intolerance or ineffectiveness, as timely intervention with glucocorticoids could be necessary to prevent complications and ensure adequate symptom management. In cases where glucocorticoids are used, the treatment should be closely monitored, and the dosage should be lowered down as soon as the patient stabilizes to minimize potential side effects.
Continuing on, there is also the use of colchicine, which is commonly used in conjunction with NSAIDs as it improves the response to therapy and the need for glucocorticoids. Similar to NSAIDs, it has anti-inflammatory properties. It inhibits microtubule formation, which in turn affects the movement and function of immune cells like neutrophils. By preventing these cells from migrating to the site of inflammation, colchicine helps to reduce the swelling and pain associated with pericarditis. However, the most significant benefit of colchicine is in its ability to reduce the recurrence rate of pericarditis. Recurrent pericarditis is a common and challenging aspect of the disease, often leading to repeated episodes of pain and inflammation. Clinical studies have shown that when colchicine is used in conjunction with NSAIDs, it significantly lowers the likelihood of recurrence, with studies showing it to half the rate of first and subsequent relapses. This makes colchicine a valuable treatment option, especially in the prevention of future episodes of pericarditis. These medications are to be used in reducing this patient's pain as much as possible, improving patient comfortability, and also reducing the psychological stress that can exacerbate symptoms.
Apart from medications being administered, there is a possibility that oxygen may be potentially required for this patient, with the SpO2 being borderline at 93% and a possible risk of deterioration which could occur with movement or during extrication. It is something to be considered. Ensuring adequate oxygenation is especially important in pericarditis, as inadequate oxygen levels can increase the workload on the heart, which is already under strain due to the inflammation of the pericardium. So, in managing pericarditis, a comprehensive approach is essential to address both the acute symptoms and long-term outcomes of the condition. This initial management plan, combining appropriate positioning, pharmacological treatment, and supportive measures like oxygen therapy, ensures effective management of pericarditis, relieving symptoms, inflammation, and preventing further recurrences.
As an approach to improve patient outcomes, in 2019, Ambulance Victoria introduced high-performance cardiopulmonary resuscitation into their guidelines. High-performance CPR is a further refined version of CPR that emphasizes teamwork, organization, feedback, leadership, and post-event reviews, whilst minimizing hands-off chest time. This refined method was rolled out in 2019 after introducing a clinical practice guideline and running a training course from February 2019 to January 2020. One retrospective study saw that the implementation of the high-performance CPR guideline led to significant improvements in CPR quality, with the compressions being performed at a depth of 5.8 centimeters at a rate of 116 compressions per minute, and with the average CPR session having nearly 90% of the time spent giving compressions. That same study found that by adopting high-performance CPR by AV also improved survival outcomes for patients, with a higher rate of survival to hospital discharge, especially for those patients with shockable rhythms. After accounting for various factors, the chance of survival to hospital discharge increased by 37%, and an astounding 70% for individuals who had shockable rhythms. These improved findings were further supported by a systematic review and meta-analysis, which found that when compared to standard CPR, high-performance CPR improved survival to hospital discharge by 32%. Additionally, high-performance CPR was found to have improvements in other areas, including higher rates of return of spontaneous circulation pre-hospital, pre-hospital defibrillation, and improved neurological outcomes.